Just a couple of reminders while Dr. Shaw is getting set up. If you could please mute your line when you're not speaking so we can eliminate background noise. This meeting is being recorded. And as we get to items that we need to vote on, I will do a roll call voting. You can aye, nay, or abstain. I will help drive the agenda, but defer to Dr. Shaw as we move through. And we have a very, very full meeting today. So buckle up and be ready, and we'll try and get through it as best we can. Whenever you're ready.
Yes, so I'll welcome everyone to the November 7th, 2025 meeting of the Therapeutics Committee. So we'll call the meeting to order, and we'll start off with any comments from OMPP.
Hi, good morning. I do have a couple items I wanted to mention. My name is Ann Kuhn. I'm one of the pharmacists with the Office of Medicaid Policy and Planning. John Ross, our OMPP pharmacy director, is currently out of the office, so please feel free to contact Carla Maxwell, Namrita Yancey, or myself in his absence. And then I did want to make a quick mention that today's recommendation proposal will include mental health medication classes, which historically have not been reviewed by the Therapeutics Committee. House Enrolled Act 1001 from this year's legislative session removed prohibition formerly in place that prevented preference on mental health drugs. So previously, all mental health medications had a preferred status. And while certain safety and utilization edits were permissible, preference and things like step therapy were not. Bids were solicited for supplemental rebates for the mental health medication classes, and today's proposals will reflect these. Dr. Ott was appointed to the Therapeutics Committee this summer and is here today not only as a T committee member, but also as the MHQAC representative. So thank you again, Dr. Ott, for serving in that dual role. And then just to note, beginning in December and going forward, Therapeutics Committee will meet ahead of MHQAC. However, for this go around, the proposals have already been brought to MHQAC, who reviewed them last month.
Thank you, Dr. Kuhn. With that, that takes us to the approval of the meeting minutes from the August 1st meeting.
Yes. So I kind of have a motion to approve the memoranda.
So moved, Dr. Shaw. Second.
All right. All right. So the motion has been moved and seconded. Are there any discussions, edits, revisions, corrections? All right.
All right.
We'll move
Hearing
to-
none. Dr. Shaw.
Aye.
Dr. Krupp.
Aye.
Dr. Marshall.
Aye.
Mr. Musial.
Aye.
Dr. Negendank.
Aye.
Dr. Ott.
Aye.
Dr. Patel.
Aye.
And Dr. Weber.
Aye.
All right, we have all ayes, so that motion will carry. Thank you. That takes us in then to our review this morning. So we are, Courtney and I are going to tag team with you since it is such a long review. So I'm going to start with the CNS and others, which, as you can imagine with mental health, is now going to be quite lengthy. And then she will finish us up with the rest. So in our CNS and others, we have no recommended changes in the classes listed here. For the agents for the treatment of opioid use disorder or overdose, we recommend that Brixadi move to preferred and then update its drug-specific PA criteria to remove its step through Sublocade. All the rest of the criteria will still stay the same. And then Zernai, which is a nalmefene product, moving to non-preferred. It was previously hanging out in neutral. For the antiemetic anti-vertigo agents, Anzamet tablets, granisetron solution for injection, and palonesitron injection maintain their non-preferred statuses and quantity limits, but adding step therapy that they must have a previous trial of ondansetron in any formulation and provide medical justification for use for why they need to use that over ondansetron. And then for the Sancuso patch, maintaining its non-preferred status and updating its step therapy that the prescriber has submitted medical justification for use of the patch over the generic granisetron tablets or injectables. For the Sustol injection, maintaining its non-preferred status, updating its step therapy or adding step therapy to have medical justification for use over the tablets and injectable for the granisetron as well. For the anti-seizure agents, there is a lot happening here, and a lot of it has to do with the movement of mental health agents. So for those of you who may not know, there were a lot of cross-indicated products on the mental health list previously that were all considered preferred. With this update, we now have kind of some shifting and some movement on some of the anti-seizure agents that have been in this class, but now we can have some different management. So just want to kind of point that out, that we're looking at some of these. So there's several products. If we aren't mentioning them and they were previously in the anti-seizure group and on the mental health list, they're going to continue as preferred if we did not make any changes to them there. We're also requesting to update the anti-seizure agent PA criteria to enforce the generic medically necessary PA for generic equivalents or the generic versions of the branded agents. So when we have a brand that's preferred over the generic, we want to require the generic medically necessary over the brand, kind of like we do for brand medically necessary when the generic is preferred. And then claims for generic products submitted with the DAW1 code will be exempt because then that's again the prescriber's DAW that they have to use the generic. And then gold card prescribers will not qualify for this exemption from criteria, so they will need to have that reviewed in the PA. All right. Carbamazepine suspension and ER tablets, the generic Tegretol, are going to stay preferred and remove their generic medically necessary criteria, so they won't have to step through the brand. Depakote, the DR and ER tabs, the brand only, will move to non-preferred, but they will still maintain their BMN criteria. For the gabapentin solution, the generic Neurontin moved to non-preferred, maintain its max daily dose of the 3,600 milligrams per day, and then add generic medically necessary criteria. For the Gabarone 100 milligram and 400 milligram tablet, move to non-preferred, maintain its max dose of 3,600 milligrams per day, and then add a step that the prescriber has submitted medical justification for use of the gabapentin tablet over the preferred gabapentin capsules. For the Lamictal chew, move to non-preferred and add BMN criteria. For the Lamictal ODT, IR, and XR tab, move to non-preferred and maintain BMN criteria. The Lamictal IR kit and ODT kit maintain their preferred status and quantity limits, and then add to the preferred brand drug list, so they will be brand preferred for those products. Lamotrigine IR kit and ODT kit, so the generics of what I just mentioned, are going to be non-preferred with their quantity limits, and now they will require generic medically necessary criteria. For the Keppra injection solution tab and XR tab, move to non-preferred and add brand medically necessary criteria. For the Lyrica capsules, maintain preferred in their respective quantity limits and remove BMN criteria, so they will be able to use the brand there. For the Lyrica solution, the brand only, maintain its preferred status, maintain its quantity limit, and then this will be preferred brand over the generic. The Midazolam injection, moving to neutral and maintaining in the sedative hypnotics benzodiazepines PA criteria. The Midazolam syrup, maintaining its preferred status and maintaining it in the sedative hypnotics benzodiazepine PA. For the Neurontin solution, this is the brand only, maintaining its preferred status and quantity limit, and then adding to the preferred brand drug list. So the Neurontin solution will be preferred over the generic gabapentin. The Onfi solution, or suspension rather, and tablet, the brand only, will move to non-preferred, maintaining their quantity limits and adding BMN criteria. So the generic will be preferred, if you will, over the brand. The oxcarbazepine ER tablets, which is the generic Oxtellar XR, moving to non-preferred and adding generic medically necessary criteria. So the brand will be preferred over that generic. Pregabalin solution, the generic Lyrica, will move to non-preferred and adding generic medically necessary criteria. So again, the brand will be preferred over the generic. Subvenite IR, this is a lamotrigine, moving to non-preferred and maintaining its quantity limits. Subvenite IR kit, moving to non-preferred, maintaining its quantity limits and adding to generic medically necessary criteria. Sympazan, which is a clobazam, moving to non-preferred and adding step therapy that they have trial and failure of the clobazam tablet or suspension and the prescriber has submitted medical justification for use of the film over the tablet or suspension. The Tegretol IR tab, maintaining preferred status and adding to the preferred brand drug list. And then the Topamax sprinkle capsules and IR tabs, moving to non-preferred and maintaining BMN criteria. And Topiramate ER sprinkle capsules is the generic Qdexy, maintaining its preferred and quantity limits with step therapy that they need to be 2 years of age or older or less than 12 or unable to swallow the capsules. The Topiramate ER capsules, the generic Trokendi, moving to non-preferred, maintaining its quantity limit and GMN criteria. The Topiramate IR solution, the generic Aprantia, moving to non-preferred, maintaining its quantity limit and step therapy and its generic medically necessary criteria. And then the Trileptal brand IR tab and suspension, moving to non-preferred and adding brand medically necessary criteria. And we just made it through anti-seizure. And if you thought that was rough, just wait, it gets better. Any questions on that? So lots of movement between brand and generic agents, right? Of what we're preferring, brand versus the generic. But in general, still a lot of the same agents that were historically preferred are preferred. All right.
Do we have information, we might talk about it later, about how many patients are going to be affected by the brand versus generic? Like how many patients are going to end up having to switch?
We should be able to see that in the second session when we look at some of that, those.
When we're talking anti-seizure agents, we have an edit in the system for the large majority of them that allows you to continue on whatever agent you've been on. So should primarily affect new starts versus those that are essentially.
Okay, great. Thank you.
All right. For gastroprotective agents, there is a celecoxib oral suspension, Viscoxa, that we are recommending to move to non-preferred with step therapy that they must be 2 years of age or older, less than 12, or unable to swallow the capsules. All right, here comes the exciting times. So you may notice, again, I mentioned that there were several products that were on the mental health utilization edit list, especially in the cross-indicated, for example, Benadryl. I'm not going to talk about Benadryl today, aside from what I'm saying right now in this moment, because we're not placing it anywhere on the PDL. So if there's a product that you did not see that was on that list, that doesn't mean it's not covered anymore or that it's not available. It is still available. We just aren't placing it on the PDL. So several cross-indicated products we won't talk about today. We aren't putting them in classes and just want to kind of make you all aware of that. All right. So these were some of the new edits that were added with the MHQAC. We're kind of talking about how we're going to provide these to the therapeutics committee going forward, if we're just going to provide them in the recommendations or if we're still going to have a table. So historically with the MHQAC meeting, any new drug or new utilization edit, we would create this table for them because we weren't placing it anywhere on the PDL or making any other recommendations. So this may look different the next time we come to you and you see it. We may or may not have the table, just want to point that out. So the escitalopram 15 milligram capsule, placing a 1 per day edit on that. And then there's a new product, Exua, which comes in an 18.2, 36.3, 54.5, 72.6, and a titration pack. All of those are at 1 per day or the 1 titration pack per 90 days, and they are indicated at age 18 years and older. And we'll also mention them as we go through the recommendations too, so they will be there. Okay, so for the first new class that we're recommending addition to the PDL, we have the Alzheimer's and dementia agents. So for our brand name agents, Aricept, Exelon, Namenda, the ER capsule titration pack, moving all of these to non-preferred, maintaining their age and quantity limits, and maintaining their brand medically necessary criteria. For Adlarity, which is a donepezil, moving to non-preferred, maintaining its age and quantity limits, and then step therapy that the prescriber must provide medical justification for use of a topical formulation or have history of Adlarity for 90 of the past 120 days. So I'm going to take another moment to point out something here, that you'll see this history of 90, the past 120 several times throughout here, and that's us allowing people to continue who have been on previously. So most of these agents in the mental health space, we didn't want to just stop somebody without being able to continue if they've been on it long term. So we're looking for those that have consistent utilization and then allowing them to continue as we move forward. So if you see that language in there, that's that continuation of therapy, and we'll have it throughout a lot of these as we go forward. All right, galantamine oral solution, maintaining its preferred status and quantity limit and adding the step therapy that they must be unable to swallow the tablet formulation. Again, similar with some of our other step therapy and edits. The memantidine donepezil, which is the generic Namzaric, moving to non-preferred, maintaining its quantity limits and generic medically necessary criteria, and then adding step therapy that they have, the prescriber has provided documentation supporting separate components are not suitable for use. And then for the brand Namzaric, moving to non-preferred, maintaining quantity limits and maintaining on the preferred brand drug list with the same step therapy that they have documentation supporting separate components are not suitable for use, or that they have history of Namzaric utilization. Zunveil, move to non-preferred, maintain its quantity limits, and then step therapy that they have a trial and failure of galantamine in any formulation, and that the prescriber has submitted medical justification for use or history of Zunveil. And that concludes our Alzheimer's and dementia agents class. Hi. Keep pushing on. Anti-anxiety and related disorders. So brand name agents, Ativan injection, Klonopin tablet, Valium tablet, Xanax IR and XR tablet, moving to non-preferred, maintaining their quantity limits and maintaining PA criteria and brand medically necessary criteria. Bucapsul is a buspirone capsule, maintaining its non-preferred, or moving to non-preferred rather, maintaining its quantity limits, and then adding step therapy that they have trial and failure of the buspirone tablet, and prescriber must provide rationale for Bucapsul over the buspirone tablet. For Igalmi, moving to non-preferred, maintaining its quantity, PA criteria, age, and quantity limits. And then Lorive, moving to non-preferred, maintaining its PA criteria and age and quantity limits. And then Meprobamate, moving to non-preferred, maintaining its quantity limits, and then adding a step therapy, must have previous trial and failure of the buspirone IR tablet and hydroxyzine, and that the prescriber has submitted rationale for use of Meprobamate over these agents, or they have history of Meprobamate use. We made it through anxiety. Hopefully you don't have anxiety after that class. And if you're feeling depressed, we'll move on to that group now. This is a little bit longer than some of the others, so you can see the group up there. Want to point out in this group, and I probably should have pointed out in some of the others, but I think this is where it's first starting. We do, even though we have this all as antidepressant agents, we have it broken out by the type of mechanism. So you have the MAOI, the SNRIs, miscellaneous, et cetera. And that's really, so when we start comparing, like in the call center and they're reviewing something that's non-preferred, they can kind of compare apples to apples if they need to, depending on the product that they're trying to request. All right. So brand name agents, Celexa tablets, Cymbalta capsules, Effexor XR capsules, Forfivo XL tabs, Lexapro, Paxil, IR, CR, and oral suspension, Pristique ER tablets, Prozac capsules, Vibrid tablets, and Zoloft concentrate and tablets. Moving to non-preferred, maintaining their age and quantity limits as they have them, maintaining PA criteria. And just of note from this group and the previous group, the benzos have a class-wide PA criteria, just as the SSRIs and SNRIs have a class-wide PA criteria around duplicate therapy. So we're not changing that as we move forward. And then maintaining the brand medically necessary criteria on these. All right. Brand name agents, Anafranil tablets, Nardil tablets, Norpramine tablets, Pamelor capsules, Parnate tablets, Remeron ODT and tablets, and Wellbutrin SR tablets, moving to non-preferred, maintaining their quantity limits as applicable, and maintaining their BMN criteria. And then lastly, in this MAOI subclass group of MSAM, Marplan, phenelzine, and tranylcypromine, I'll get there, move to non-preferred, maintaining their quantity limits and step therapy that they have previous trial and failure of one SSRI and one SNRI agent for at least 4 weeks, and the prescriber has submitted medical justification for use or history of the requested agent in the past. And this is just around current guideline recommendations and safety and a whole host of things when using NMAOI. All right, the bupropion ER generic Forfivo XL 450 tablet, moving to non-preferred, maintaining its quantity limit and adding step therapy that the prescriber has submitted medical justification for use of the 450 milligram tablet over the preferred bupropion agents, as they can get a 300 milligram and 150 milligram tablet in the other product. So if for some reason they're having issues with compliance or needing a singular tablet or something with the inactive ingredients, they could submit PA for that. Citalopram capsules, moving to non-preferred, maintaining their quantity limit and PA criteria, and then step therapy that they must have previous trial and failure of the citalopram tablet and medical justification for use of the capsule over the tablet or history of use of the tablet. Capsule, sorry. And then citalopram, escitalopram, and fluoxetine oral solutions, maintaining their preferred status and quantity limits and PA criteria, and then adding step therapy that they must be under 12 years of age or 12 years of age and older and unable to swallow the capsule tablet formulation. For the Drizalma sprinkle, this is a duloxetine product, moving to non-preferred, maintaining its quantity limits and PA criteria, and then adding similar step therapy, must be 12 years of age or under 12 years of age or 12 years of age and older and unable to swallow the capsule formulation. For the escitalopram capsule, moving to non-preferred, adding a quantity limit of 1 capsule per day. We mentioned that earlier in the table, adding them to the duplicate SSRI, SNRI, PA criteria, and then step therapy that they have previous trial and failure of the escitalopram tablet, and they have medical justification for use of the capsule over the tablet, or they have history of the capsule. Exua tablets, moving to non-preferred, adding a quantity limit of 1 tablet per day and 1 titration pack for 90 days, the age limit of 18 years of age or older. We mentioned this earlier in the table again. And then step therapy that they must have trial and failure of 2 preferred antidepressant agents for at least 4 weeks each. This can fall in any category on that side of the PDL. It doesn't necessarily just have to be an SSRI or SNRI. It can be any of the agents within that group or history of the requested agent. Fluvoxamine ER capsules, moving to non-preferred, maintaining PA criteria and maintaining any quantity limits, and adding step therapy that they must have previous trial and failure of fluvoxamine IR tablet formulation, and the prescriber has submitted medical justification for use of the ER over the IR or history of the ER tablet, or capsule rather. Nortriptyline oral solution, maintaining preferred status, maintaining their quantity limit, and adding a step therapy, must be under 12 years of age or 12 years of age and older and unable to swallow the capsule formulation. Paroxetine oral suspension, maintaining preferred status, age, and quantity limits, and maintaining their PA criteria with step therapy that they must be unable to swallow the tablet formulation. We don't have the age in here because paroxetine's at 18 for their age indication due to safety risks. Valdesi, which is a trazodone oral solution, moving to non-preferred, maintaining its quantity limit, and then adding the step therapy of must be under 12 years of age or 12 years of age and older and unable to swallow the tablet. Sertraline capsules, moving to non-preferred, maintaining their quantity limits in PA, and then adding step therapy that they have trial and failure of the sertraline tablet and justification for use, or that they have history of the capsule use. Sertraline oral concentrate, maintaining its preferred status, quantity limit, and PA criteria, and again, adding step therapy that they must be under 12 years of age or 12 years of age and older and unable to swallow the tablet formulation. And then Spravato, moving to non-preferred, maintaining its PA criteria, age, and quantity limits. So even though this will be non-preferred, the criteria is not changing, and so they'll just continue to meet the criteria in the same way that they do today. And it really doesn't change anything as far as that goes for that product. Trimipramine capsules moving to non-preferred, maintaining their quantity limit, and then must have trial and failure of all preferred tricyclic antidepressants or medical justification for use. We just got through antidepressants. Any questions before we go on to the antipsychotic, anti-manic agents? I hope nobody's gotten psychotic after we've gone through these, but there are some agents to treat it. So our brand name agents: Abilify, Clozaril, Geodon, capsules and IM solution, Haldol, Decanoate IM solution, Invega tablets, Latuda tablets, Risperdal oral solution and tablets, Saffris SL tablets, Seroquel, IR and XR, Symbyax capsules, Zyprexa IM solution and tablet, and Zyprexa Zydis ODT, moving to non-preferred, maintaining their age and quantity limits, maintaining their PA criteria, and maintaining their BMN criteria. And just again, another note, we do have these broken out again by first generation miscellaneous, second generation, and then anti-manic. For brand named agents, Lithobid ER tablets moving to non-preferred and maintaining BMN criteria. And then I'm pretty sure none of us could have seen this coming from a mile away, but Abilify MySite that tracks you when you take it is no longer, is CMS termed and not available. So we're removing it from coverage. Aripiprazole ODT, maintaining its preferred status, PA criteria, age and quantity limits, and then adding step therapy that they must be under 12 years of age or 12 years of age and older and unable to swallow the tablet formulation or history of use. The aripiprazole solution, maintaining its preferred status, PA criteria, age and quantity limits, and then again must be under 12 years of age, 12 years of age or older, and unable to swallow the tablet formulation or history of use. The clozapine ODT, maintaining its preferred status, PA criteria, age and quantity limits. And then they must have trial and failure of the clozapine tablet, and the prescriber has submitted medical justification for use of the ODT or history of use of the ODT tablet. Cobenfy, moving to non-preferred, updating its drug-specific PA criteria and maintaining its age and quantity limits. Fanapt, the tablet and titration packs, moving to non-preferred, maintaining age and quantity limits, and then adding step therapy that they must have trial and failure of one preferred antipsychotic agent or medical justification for use or history of Fanapt. Lithium solution, maintaining its preferred status, again, adding the age, must be under 12 years of age or 12 years of age and older and unable to swallow the capsule tablet. Nuplazid, moving to non-preferred, maintaining its quantity limit and updating its drug-specific PA criteria. So we just tightened up the language around the criteria and the diagnoses, but still, if somebody has that diagnosis of Parkinson's-related psychosis, then they will, and meet the other criteria, they'll have access. For Opipsa film, it's an aripiprazole film, moving to non-preferred, maintaining PA criteria, age and quantity limits, and then step therapy that they have trial and failure of the aripiprazole tablet, and the prescriber has submitted medical justification for use, or that they have history of Opipsa. Perseris IM injection is no longer manufactured, so we need to remove that from coverage. Pemazide, moving to non-preferred, maintaining PA criteria, age and quantity limits, and then step therapy that the member has trialed and failed 2 of the following for 4 weeks each: aripiprazole, haloperidol, risperidone, or they have history of Pemazide. The risperidone microspheres injection solution, so this is the generic Risperdal Consta, moving to non-preferred, maintaining its PA criteria, age and quantity limits, and then maintaining its generic medically necessary criteria. So the brand is preferred over the generic here. The risperidone ODT, maintaining its preferred status, PA criteria, age and quantity limits, and then again, step therapy around under 12 years of age or over 12 years of age and unable to swallow the tablet formulation or history of use. The risperidone solution, this is generic Risperdal, maintaining its preferred status, PA criteria, age and quantity limits, and then again, the age criteria of under 12 or over 12 and unable to swallow or history of use. Rakindo is a risperidone IM injection. They are no longer participating in the MDRP, so we need to remove them from coverage as well. Sequado patch is a acetapine patch, moving to non-preferred, maintaining PA criteria, age and quantity limits, and then Step therapy, that they have trial and failure of the acenapine SL formulation or sublingual formulation, and they prescriber has submitted medical justification for use, or they have history of the patch. Versaclause, which is the clozapine oral suspension, moving to non-preferred, maintaining PA criteria, age and quantity limits, and then step therapy that they must be unable to swallow the tablet formulation. And we've made it through the antipsychotics, and we're on to insomnia.
So this is Dr. Shaw. So I'm going to ask a question of Dr. Ott. So looking at the proposed antipsychotic criteria, is clozapine such a keystone agent?
Mhm. Yeah, so
mean-
clozapine is,
Go ahead, Amanda.
no, you go ahead.
No, I was just going to say, I mean, it is a drug that we have been using much more frequently over the last decade or so. And so we have moved it up earlier, I think, in treatment than we have in the past. And especially with the removal of the REMS, it's facilitated some use of clozapine. The Versaclose, I mean, the sublinguals and things like that are not really used.
Okay.
Yeah, this
Well,
is
right.
Dr. Duggan.
So I
If
think
I can,
the-
if I can
The
start,
proposed, right, but for the proposed criteria, in order to access duplicate antipsychotic agents, you have to have had a prior 4-week therapy of clozapine.
Just for schizophrenia or psychosis.
Right,
And that's guideline,
anti-
like that's in the guidelines that they recommend clozapine, clozaril or clozapine use. Right, Dr. Ott, that hasn't changed as far as I know. Clozapine is still recommended for treatment resistant schizophrenia.
Oh,
before
yeah.
you go to
And
duplicate
so-
therapy.
Yeah, from the Mental Health Quality Advisory Committee perspective, this has been in place actually for a while. So, Amanda, if you back me up on this, but this is something that we've been doing for a while, where there is at least a clinical justification for use of dual antipsychotics. And if clozapine has
Why we
not
don't
been
use it.
used, what the reasons are for not being able to use clozapine. So if it's somebody who has not been able to get lab draws or has other issues related to clozapine, other of the potential side effects that occur with it, then they can get the dual antipsychotic therapy without getting clozapine. But that's been in place for a while.
Yeah, probably 10 plus years at this point, just based on guidelines. So it was,
Mhm.
when we first put it in, I'm sure Dr. Ott remembers, like there was quite an uproar because prescribers at that time were very like hesitant about using clozapine, but really after the first year, we kind of had a pretty good shift and we haven't really had any.
oh, so
Issues with it
this
since
was a
then.
prior issue to MHQAC. I was reading through the criteria, I was like.
Yeah, this has been.
mandate and of course, specific agent use.
Yeah.
Yeah, I mean, I think also at the time that this was put in place, there wasn't a lot of evidence for dual use of antipsychotics. And while we now have some increases, especially where we see like clozapine plus a partial agonist like aripiprazole, there's some growing evidence base. And so these may need to be considered as that evidence base grows to see what potential combinations could be useful based on clinical evidence. But yeah, right now, this has been in place for a while.
I mean, this is not my field, but it was just sort of
Mhm.
a little, I don't think we mandate a specific agent necessarily.
Well, I mean, we're not mandating in the sense of like, you can't use a singular agent,
Right.
but if
There
you're
are-
trying to get to do duplicate therapy, like that's what the guidelines say is before you go to duplicate therapy, you should have tried clozapine
Clozapine.
because there's evidence base to support its use in
Mhm.
treatment resistant.
Okay, thank you for the education.
Of course. Thank you for the questions. Thanks, Dr. Ott.
Sure.
All right. Any other questions before we move on to insomnia? All right, for the brand name agents Ambien, CR and IR, Doral tablets, Halcyon tablets, and Restoril capsules moving to non-preferred, maintaining their quantity limits, PA criteria, and BMN criteria. And then the brand name agents Rosarum and Silanor tablets moving to non-preferred, maintaining their quantity limits and BMN criteria. So again, these are broken out between benzodiazepines, sedative hypnotics, and then miscellaneous in this group. Dayvigo, moving to non-preferred, maintaining its age and quantity limits and PA criteria, and then adding step therapy that they must have trial and failure of Belsomra, or prescriber has submitted justification for use of Dayvigo over Belsomra. For Edluar, the Zolpidem 5 and 10 milligram sublingual tablets, moving to non-preferred, maintaining their quantity limits and PA criteria, and then adding step therapy that they must have trial and failure of the Zolpidem tablet. And prescriber has submitted medical justification for use of the sublingual over the Zolpidem tablet. For the Flurazepam, moving to non-preferred, maintaining its quantity limits and PA criteria, and adding step therapy that they must have trial and failure of all preferred benzodiazepine agents for insomnia or medical justification for use. And then Hetliaz and Hetliaz LQ, moving to non-preferred, maintaining its age and quantity limits, maintaining on the preferred brand drug list, and then updating its drug-specific PA criteria. And then Quazepam, moving to non-preferred and maintaining its quantity and PA criteria, and then adding step therapy that they must have trial and failure of all preferred benzodiazepine agents for insomnia or medical justification for use. Quvivic, moving to non-preferred, maintaining its age and quantity limits and PA criteria, and then again, step therapy that they must have trial and failure of Belsomra or medical justification for use. And then Tazimelteon capsules, the generic Hetliaz, moving to non-preferred, maintaining its age and quantity limits, maintaining its generic medically necessary criteria, and then updating its drug-specific PA criteria. And then Triazolam, moving to non-preferred, maintaining its quantity limits and maintaining its PA criteria. Zolpidem, the 7.5 milligram capsule, moving to non-preferred, maintaining its quantity limits and PA criteria, and then step therapy that they have trial and failure of the Zolpidem IR 5 milligrams. And then the Zolpidem 1.75 milligram and 3 milligram sublingual tablets, moving to non-preferred, maintaining its quantity limits and PA criteria. And then the prescriber has submitted medical justification for use of the Zolpidem sublingual tablets, and that the member is not using this with any other Zolpidem strengths or formulations. Question?
Yes. Okay, so Doxepin is an agent with other utilization. So right now, Doxepin is a PDL neutral agent.
It will be listed as preferred in
The generic side.
right, but it's still preferred, the generic is, right? Because we moved the brand over, but if you see like up on there in the miscellaneous, see Doxepin listed, so it will be preferred, like open without PA criteria. Unless you feel like that should change.
Right, well, because for insomnia, it's only the very, very low dose that's indicated for insomnia. And of course, from a geriatrician standpoint, it's a highly potent anticholinergic medication. So I can see the difficulties with this agent because of its different utilization. Okay. All right.
I mean, if you want to consider looking at PA criteria in geriatrics, I mean, that's certainly something we can look at too. Just recognizing that most of our individuals are going to be duals and not really fall into our coverage, but it's certainly something that we could evaluate if you felt like that was worthwhile.
Okay. Thank you.
Mhm.
You can specify this, like, so this is specifically the 3 and 6 milligrams. So that's helpful.
Oh. So you think
We can list the 3 and 6 milligram.
okay.
You make a note to do. We'll list that on the PDL just so it's
Okay.
known that it's the 3 and 6 milligram.
Okay. So you feel like you can take care of it from a administrative
Yeah,
standpoint?
I think so. We can just list it on there. Or consider it listed, and then if you have concerns about it being listed, let us know in the third session, and you can tell us, don't list that on there, or don't put something else different. Are the non-Silenor neutral? They're preferred, okay.
So for the GI indications, it's still preferred? Or is it non-preferred? Because I don't think we review it.
I was gonna say, I didn't think we reviewed it either. We'll look at that.
Okay.
I think they may be neutral, so it may be something that we may want to, if we want to look at the other ones at some point, we can take that back.
Okay.
Any other questions about insomnia before we move on to narcolepsy? The opposite. All right, so the brand name agents, Nuvigil tablets and Provigil tablets, moving to non-preferred, maintaining their age and quantity limits as they have them, maintaining their PA criteria and their brand medically necessary criteria. Sodium oxybate, moving to non-preferred, maintaining their age and quantity limits, maintaining PA criteria and adding generic medically necessary criteria. So the brand will be preferred over the generic in this case. Sunosi, moving to non-preferred, maintaining its age and quantity limits, and then updating its drug-specific PA criteria, and then continuation of therapy is managed in its reauth criteria so that those who are currently on it would be able to continue. And then Wakix, moving to non-preferred, maintaining its age and quantity limits, and updating its drug-specific PA criteria, and again, the continuation of therapy for that is managed in the reauthorization criteria. Xyrem, maintaining its preferred status, age and quantity limits, and PA criteria, and then adding to the preferred brand drug list. And then Xywav, moving to non-preferred, maintaining its age and quantity limits, and then updating its drug-specific PA criteria. And again, the continuation of therapy is managed within that reauth criteria. All right. We're on to the non-stimulant ADHD, which gives you a hint that there's a stimulant ADHD. And it's quite large, so we'll do the smaller one first. For the brand name agents, the Catapress TTS patch, the Intuniv ER tablet, and the Strattera capsule, moving to non-preferred, maintaining their age and quantity limits as they have them, maintaining their PA criteria as they have them, and then maintaining brand medically necessary criteria. And then Qelbree, maintaining preferred status, age and quantity limits, and maintaining their PA. Then adding a step therapy of previous trial and failure of a preferred ADHD agent. This can be a stimulant or a non-stimulant, or history of Qelbree. And that's it for that. And then we're on to the stimulants, which have a lot. All right, bear with me. We got a lot of brands in here. Okay. For the Adderall IR tablets, the Adderall ER and XR capsules, the Uptensio XR capsules, Concerta ER tablets, Dazoxin tablets, Dexedrine ER, Avicchio tablets, Focalin IR tablets, Focalin XR capsules, Metadate CD capsules, methylene solution, Ritalin tablets, Ritalin LA capsules, and Zenzetti tablets. Moving to non-preferred, maintaining their age and quantity limits, maintaining their PA criteria as applicable, and the BMN criteria. And so a reminder, we do have a duplicate stimulant PA criteria in place as well. For the non-preferred agents, adding the following step therapy. So this is going to be like a global step therapy unless we say something otherwise. So if it's non-preferred, it must have a trial and failure of 2 preferred stimulants that are different chemical entities or medical justification for use of the non-preferred agent over the preferred agents or history of use. We do have some other ones that we do have step therapy that we specify different, but if we don't specify, this will be the step therapy that goes throughout. For Adzenys XR ODT, moving to non-preferred, maintaining its age and quantity limits, maintaining its PA criteria, and maintaining on the preferred brand drug list, with step therapy that they must have trial and failure of Dianavel XR chew or suspension or medical justification for use or history of the Adzenys. For the amphetamine ER ODT, this is the generic Adzenys, moving to non-preferred, maintaining its age and quantity limits and PA criteria, and then maintaining its generic medically necessary criteria. So again, even though these are both non-preferred, the brand is just a little more preferred than the generic. For the amphetamine, dextroamphetamine, this is the generic Mydayis ER capsule, moving to non-preferred, maintaining its age, quantity limits, and PA criteria, and then adding step therapy that they must have trial and failure of amphetamine, dextroamphetamine ER capsules, that's the generic Adderall XR, or medical justification for use, or history of the generic Mydayis. For Contempla XR ODT, this is a methylphenidate product, moving to non-preferred, maintaining age and quantity limits, maintaining PA criteria, and then add the non-preferred step therapy requirement that we mentioned earlier. For the dextroamphetamine solution, maintaining its preferred status, age and quantity limits, and PA criteria, and then adding step therapy that they must be under 12 years of age or 12 years of age and older and unable to swallow the capsule tablet formulation. For the Jornay PM, maintaining its preferred status, age, quantity limits, and PA criteria, and then having step therapy that they must have trial and failure of at least one preferred long-acting methylphenidate product or medical justification for use of Jornay PM or history of Jornay. For the lisdexamphetamine capsules, this is the generic Vyvanse, moving to non-preferred, maintaining its age and quantity limits and PA criteria, and then maintaining its generic medically necessary criteria. For the lisdexamphetamine chewable tablets, moving to non-preferred, maintaining its age, quantity limits, PA criteria, and generic medically necessary criteria, and then adding the step therapy that they must be under 12 years of age or 12 years of age and older and unable to swallow the capsule. For the methylphenidate ER capsules, this is the generic Abtensio XR, moving to non-preferred, maintaining its age, quantity limits, and PA criteria, and then adding step therapy that they must have trial and failure of at least one preferred long-acting methylphenidate product or medical justification for use or history of the generic Abtensio. For the methylphenidate patch, this is the generic Daytrana, moving to non-preferred, maintaining age and quantity limits, maintaining PA criteria, and generic medically necessary criteria. The brand Daytrana is preferred and over the generic. And then Procentra solution, moving to non-preferred, maintaining its age and quantity limits and PA criteria. For the Relexi, moving to non-preferred, maintaining age and quantity limits and PA criteria, and then add the non-preferred step therapy requirement. And then the Vyvanse chewable tablets, maintaining preferred status, age, quantity limits, PA criteria, maintain it on the preferred brand drug list, and then adding step therapy that they must be under the age of 12 or 12 years of age and older and unable to swallow the capsule. For the Zolstrom, this is the dextroamphetamine patch, moving to non-preferred, maintaining age, quantity, and PA criteria, and then step therapy that they must provide medical justification for topical formulation. And that concludes the mental health group, the stimulants. And then we'll go on to the other CNS.
This is Dr. Negaday. Can I ask a quick question about the stimulant
Yeah.
group? It feels like that was very quick, so maybe my brain hasn't caught up, but it feels like there's quite a few of the XR and ER formulations that moved into non-preferred. Is there still some that are staying preferred, the XR or the ER, since that's the preferred formulation to prescribe?
There are, yeah. So the amphetamine,
Okay.
dextroamphetamine, ER, right? The generic Adderall XR is going to be preferred still. And there's still, I think it's the generic Concerta is still preferred.
Okay, so more than the name brand is what we were talking about. But
yeah.
okay, gotcha. Thank you.
Yeah. Any other questions before we finish up the CNS and others? The class that keeps giving.
For the
Yeah.
ADHD meds, it looks like there's still going to be plenty of options, but is there going to be any particular communication with pediatrics or bulletins sent out to the Indiana chapter of the AAP or anything like that, just to say hey, this is a big switch, thinking ahead. Otherwise, there's going to be a lot of primary care docs who are going, what the heck just happened?
So we do put out we put out a notice in advance every time. But I don't know, as far as OMPP, is there any plan to notify any of the pediatric groups?
We do not have anything in the works to do that. We do have,
I mean, the vast majority of the agents are still going to be preferred. Really, most of what's moving is going to be the brand agents that they already would have needed PA for. There are a few that are moving, but in most of those cases, they still allow for history of use, history of use of the product. So I think it's going to be relatively low impact.
Okay. I was just thinking because we're creatures of habit and people will tend to prescribe the things they're used to prescribing. And if all of a sudden
Sure.
they're getting PA requests for new starts on things that they've never gotten PA requests for, there's going to be a lot of confusion. I
And
don't know if we
Dr.
have
Ott,
any idea of how many that's going to impact.
and And I understand where you're coming from, Dr. Otts. So what I would offer is that, once the DUR board approves the T committee recommendations, you are welcome to reach out to the medical societies. Because, for example, when we went through the whole big statin changes about I don't know, 10 years ago, I drafted some articles that got distributed to the internal medicine providers regarding the pending changes, just to help give them another heads up about what was coming down the road. So I would encourage, we are representatives of our disciplines, and I think in some ways that also is a means to sort of help educate our peers about what sort of changes might be coming down the road.
Yeah, I think that's certainly something, and I'm happy to, like, if somebody wants a copy of the bulletin that we post online to be able to distribute, we're happy to get that to you, or the website link.
Yeah. Yeah, I think
Yeah,
the
and-
state is somewhat limited in terms of its communication mechanisms. But we can
Well,
help try to further.
Amanda, if you could make sure you send that to me when that comes out. I'm doing a talk for the mental health symposium in December, and I'll cover all this there.
Okay, perfect. I'm making myself a note to remember.
Thanks.
Any other? No, thank you. Any other questions on the mental health agents? All right. Wrapping this up, we did in the narcotics updated the MME edits for 2026 through 2027. Last I checked, we were at 325 MMEs as of October 1st. So we're continuing to work our way down. I believe we're going to look at slowing down the taper. We did already as we start to get some of the lower doses, just because we want to stay within that small range. I think it's 10% or less, or something in that range of, so we don't move people as we get to these lower doses too quickly. But we are, we went from 1,000 to 325. So we've made a lot of progress, even though it still seems like we're super high and it doesn't seem like a lot. When you started at 1,000, 325 is like, we're making headway. We're doing pretty good. In the skeletal muscle relaxants, there is a new cyclobenzaprine Tabmaya sublingual tablet moving to non-preferred. It was previously neutral, adding a quantity limit of 2 sublingual tablets per day, and then step therapy that they must have trial of the cyclobenzaprine IR tabs within the past 30 days. And that concludes our CNS and others, which will now forever be the longest class that we ever go through every time. When you thought Timmy's were the longest one, we have beat it now. Any questions before I let Courtney take it away for the rest, and you don't have to hear me drone on anymore?
You definitely have the harder job.
All right,
You gonna forward me or you want me to do it, or
up to you.
if you're comfortable doing it, just let me know if I need to take over.
Okay.
Okay, hello, everybody. All right, for dermatologic agents, the acne agents, we have the Erie Gel 2% gel brand name. We're removing from SEPDL. It's no longer manufactured and CMS termed. For the anti-psoriatics, we have the Vtama. We're going to move that to preferred status and move it down into the topical immunomodulators drug class and adding it to that PA with drug-specific criteria. And that concludes dermatological. All right, endocrine classes. These are the classes with no recommended changes. For the bone resorption inhibitors, we have a bunch of new, what do you call those? Biosimilars that we need to place. So we have Bildios, which is moving to non-preferred and adding to the bone resorption inhibitors PA criteria. With drug-specific criteria, and the Bilprevda moving to non-preferred and adding it to the PA. So the Bildios is the biosimilar for Prolia. The Bilprevda is the biosimilar for the Xgeva. And then we have Bomintra and Osenbelt. Those are going to be moving to non-preferred. and adding to the PA criteria with a step through Bilprevda. So the Bilprevda and the Bildios are going to be our more preferred, non-preferred agents. We're going to direct all the other products through them. The Connexins and the Stoboclo moving to non-preferred, and again, adding to the bone resorption inhibitors PA with a step through the Bildios. Jubbonti and Prolia remaining the non-preferred statuses and updating their PA criteria to step through Bildios. Then lastly, the
Hi.
Wyost and the,
No, no, no.
sorry.
I said I'm gonna text her and see if she's free.
Well, then I got her. Oh, can't get her.
okay, the Wyost and the Xgeva, we're maintaining non-preferred status, and then we're updating the criteria to have a step through Bilprevda. Okay, and DPP4 inhibitors, we have Brinovin, an oral solution that we're moving to non-preferred, and we're adding the step therapy that must be 18 years of age or older and unable to swallow. Janumet XR, we're moving to non-preferred and updating the step therapy to have tried a preferred combination agent for 90 of the past 120 days or medical justification for use. And then the sitagliptin freebase, metformin ER, the generic Zituvimet XR, we're going to move to preferred status, remove the GMN criteria, and update that step therapy to have tried metformin for 90 of the past 120 days or provide medical justification for use. For growth hormones, in Ngenla, we're maintaining non-preferred status, and we're updating the drug-specific PA criteria to remove the step through Sogroya, but we are going to maintain the step through Skytrofa. Skytrofa, we're maintaining preferred status and then updating the PA to include the expanded indication for replacement of endogenous growth hormone in adults with growth hormone deficiency, and removing the drug-specific age limit that we currently have in the PA. For the Sogroya, we're moving that to non-preferred, and we're updating their PA criteria to add a step through Skytrofa. For insulin's intermediate acting, the Humulin N Quick Pen, we are moving to preferred. The Novolog mix, 70/30 Flex Pen vial, moving to preferred. The Humalog vial, we're moving to preferred. The insulin Lispro vial, moving to non-preferred. Marilog pen and vial, we're adding that to non-preferred. And then Novolog, all formulations will be moved to preferred. For SGLT inhibitors, we have Glixambi, we're going to move to preferred and remove the step therapy requirement. Qturn, we're going to maintain the non-preferred status and update the step therapy to have trial and failure of Glixambi or combination therapy with preferred agents of the same classes, or the prescriber has submitted medical justification for use. Steglojan, maintaining non-preferred status and also updating step therapy to have tried and failed Glixambi, or combination therapy with preferred agents of the same classes, or medical justification for use. Testosterones, androderm patches, we're removing from the SUPDL and removing quantity limits, and we're removing it from the testosterone's PA criteria. It is no longer manufactured in CMS terms, just the brand name. Urea cycle disorders, the glycerol phenylbutyrate, the generic Ravicti, we're maintaining non-preferred status and maintaining the PA criteria, and we're adding GMN PA criteria. The Olpruva, we're maintaining non-preferred status and updating the age limit within the PA criteria to include those 1 year of age or older and weighing at least 7 kilograms. Ravicti, brand only, we are maintaining the non-preferred status and the PA criteria, but we are adding this to the preferred brand drug list. And for all the agents in this class, we are updating the reauthorization PA criteria to include submission of evidence of continued benefit. So, for example, lower plasma ammonium levels or fewer hyperammonemic crises. And that concludes endocrine. Any questions? All right, estrogen and related, we have no recommended changes for contraceptives. For the estrogen and related agents, we have the conjugated estrogens, the generic Premarin. We would like to maintain preferred status, but add GMN criteria, generic medically necessary criteria. S-Trace brand name tablet, removing from the SUPDL, no longer manufactured, CMS termed. And then the brand name Premarin tab, we would like to maintain preferred status and add that to the preferred brand drugs list. For Linkuet, we are moving to non-preferred and adding to the menopausal symptom suppressant PA, which is previously known as the Veoza PA, with drug-specific PA criteria. That should conclude, yep, estrogen and related. Okay, we have no recommended changes for both GI and GU this time.
Oh.
For hematologic agents, here's the classes we have no recommended changes in. For direct oral anticoagulants, we have the Eliquis sprinkle capsule. We would like to move that to preferred and add a quantity limit of 4 caps per day for 7 days and then 2 caps per day thereafter. And a step therapy of member is less than 18 years of age and weighs 2.6 kilograms to less than 4 kilograms. And then the Eliquis soluble tablet, we would also like to move to preferred and add a quantity limit of up to 32 tabs per day for 7 days, and then up to 16 tabs per day thereafter, with a step therapy of member is less than 18 years of age and weighs 4 kilograms to less than 35 kilograms. We are adding a new drug class, hereditary angioedema agents. The Andembry, we would like to move to non-preferred, Cinryze to preferred, Donzera move to non-preferred, Haegarda move to non-preferred, Orladeyo move to preferred, and Takhzyro move to preferred. For leukocyte stimulants, Niposi, we would like to add to non-preferred. It's previously excluded, but it is going to be joining the MDRP as of 1/1. So we're adding it to non-preferred in the short-acting agents subclass. And then the Ryzneuta, we are adding to non-preferred in the long-acting agents. That concludes hematologic. For topical agents, we have no recommended changes in these classes. For dry eye disease or keratoconjunctivitis, the TRIP tier, we would like to move to non-preferred and add to the dry eye disease or keratoconjunctivitis PA with drug-specific PA criteria and quantity limit. And the class-specific dispensing terms apply. So we have a no more than 30-day supply may be dispensed at a time for the class. For topical antiparasitics, Natroba brand name, we would like to move to non-preferred, maintain the class-specific quantity limit of 1 bottle or 1 tube per claim, remove from the preferred brand drug list, and add the brand medically necessary criteria. For Radic 10% lotion, we would like to move to non-preferred and add the class-specific quantity limit. And then Spinosad generic Natroba, we would like to move that to preferred, maintain the class-specific quantity limit, and remove the generic medically necessary criteria. For topical immunomodulators, Anzupco is a new product. We would like to move to non-preferred and add to the topical immunomodulators PA with drug-specific PA criteria that includes age and quantity limit. Eucrisa, we would like to maintain preferred status and update drug-specific PA criteria to include indication review and quantity limit. Upsilura, maintain preferred status and again, update PA-specific PA criteria to include age limit expansion for atopic dermatitis indication. Zoryve 0.05% cream, move to non-preferred, add to the topical immunomodulators PA with drug-specific PA criteria, including age and quantity limits. The Zoryve 0.15% and 0.3% cream, maintain the non-preferred statuses and update the quantity limit within the PA criteria to 360 grams per year. And the Zoryve 0.3% foam, maintaining non-preferred status, updating quantity limit to 360 grams per year, and adding the plaque psoriasis of the scalp or body indication with indication-specific PA criteria. And then again, for all these agents in the topical immunomodulators, PA, we would like to add in the reauthorization to include submission of chart documentation demonstrating positive clinical response to therapy. Any questions about recommendations?
Any new business before we go over opioid reporting? All right, hearing none. This is our data from September of 2025. So we did have just a slight increase in the total utilizers from August, but then also decreased our new utilizers from August. Our kiddos or those under 18 have been relatively steady state with that number, as well as steady at that around 4.5 days-ish. So that's where we'd like to see that. You can see over to the right that anybody above 500 are PA exempt, and that we just have a few now between the 250 to 500 that aren't PA exempt as we work our way down. Again, we're at 325 right now, with the vast majority of our individuals being in the less than 90. If we look at, here's kind of graphically what it looks like for the people that we have that are not PA exempt above 90. So very small numbers. Most of our people, again, are less than 90 or PA exempt. And then if we look at our trending graph over time, just a reminder, the greenish color at the bottom is our current utilizers that are adults. The cranberryish color is our new utilizers. And then the purpley blue at the top is our current utilizers that are kiddos are less than or equal to 18. So overall, like, we had a period where we were kind of going down, then we had a period where we were kind of going up just slightly. And now we've kind of been holding at the steady state, I would say, for the past really 4 to 5-ish months. It's kind of been fairly consistent, just slight changes here and there. So just continuing to monitor, but overall, kind of what we've been seeing for quite some time now. If we look at our less than 90 group, I mean, they are basically flatlining out on us. They're very steady in our less than 90. A little more volatility when we look at the above 90, but again, we're talking very small numbers. So just a few people moving here or there can skew that a little bit. So you'll notice the 90 to 120 has gone up a little bit here over the past couple of months. A little counterintuitive, I guess, is you might notice the orange line, the 250 to 500 also kind of went up a little bit. And you might be thinking, how is that possible since we're decreasing that line down? I don't really have a great answer to that, aside from it's a very small number of people. So it could just be somebody that was in, the 250 range, went into a little bit higher than 250, but spoiler alert, they're going to have to go down or be PA exempt. So again, overall, relatively steady within this group, or what we expect to see with our very small numbers when we're tracking. Any questions on that or any other new business? All right. If you thought we had a lot earlier, we've got a lot of public comment today. So let me get my timer all set for us, and we will get going. All right. So first up, we have Dr. Odabayi for first drug is for Austedo, second drug is for Uzedy from Teva. Have it. Anybody in house? I don't see anybody in house. Let me look online. I don't see them online right now either, so we'll check back on that. Next up, then I have Dr. Lee with Qelbree from Supernus. Okay.
Hi, all right. Before I testify, I just want to make sure I understand that Qelbree is on preferred status and access with any one failure of any ADHD medication. Is that correct?
Yes.
Because it moved pretty quick. I was like.
Yeah, I'm pretty positive, but let me just make sure.
I appreciate it. Thank you very much.
Yes.
Okay.
Preferred ADHD agent, either a stimulant or non-stimulant.
Okay, well, in that case, I appreciate the committee's time. I just defer my time back to you.
Okay.
And thank you very much.
Thank
Appreciate
you.
it. Yeah.
All right, next up, we have Andrea Hawkinson for Carbaglu. I don't see online, maybe. Andrea? Don't see them either. All right. Next up, I have Taylor Francis Chapman for Izofre.
Hi, I apologize. I just want to thank you for, this is Taylor Chapman. I just want to thank you for our Zofri being recommended for the preferred status. And if there aren't any questions, I will give you your time back.
Thank you.
Thank you.
Any questions from the committee? All right. Next up, I have Dr. Martin for Orladio.
Good morning. This is Jeff Martin with BioCryst Medical Affairs. In light of the recommendation for preferred status in the hereditary angioedema class, I'd like to thank the committee and give my time back, but would be willing to answer any questions that you might have.
Any questions from the committee for Dr. Martin? All right, thank you very much.
Thank you.
Next up on the list, I have Dr. Nee with Zurzuvae.
Hi, thank you for the opportunity as well. Like the last speaker, I'll also yield back my time. Thank you.
Thank you. Next up, I have Candace, I think it's Zizalis, maybe for Neffy?
Zizalis. Yes, Zizalis. So I did not hear any review for the Neffy versus the nasal epinephrine. So today, I understand you don't have any suggestions that you just reviewed, correct, before I start?
No changes. No changes.
Yes, no changes to the current status.
Changes. I'm going to go ahead and turn my camera off for you then. I just want to talk briefly about Neffy. If you have the opportunity, the nasal epinephrine free. It's for emergency treatment of type 1 allergic reactions, including anaphylaxis in patients 4 years and older and weighing at least 15 kilograms. Know that Neffy addresses a lot of the concerns that patients that have this anxiety from using autoinjectors. Is well documented, avoiding any delays and using epi as soon as possible to treat that need for reducing the doses of additional biphasic reactions and ER visits. I do also want to mention that these risks really elevate that anxiety, and after hearing that CNS class, wow, it's something that we have to think about as clinicians. Also, there's extensive clinical studies with various allergic conditions that demonstrate Neffy's ability for PK and PD safety profiles and allowing for real-world efficacy studies currently on oral food challenges, which also confirm Neffy's rapid and effective response. And lastly, I'd like to just bring up that having a delivery much as a spray, like a Narcan or some of the other things that you've seen in the market, it really does help patients carry it with them at all times, right? There's a longer shelf life for you and your steering committee. 24 months to 30 months means that patients don't need to annually refill, but instead they have the other opportunity to have them on hand and keep them close by. It's effectively cutting half the cost. Better shortage of storage conditions and stability, and dose excursions or during excursions or heat, where y'all are in Indiana, the cold, even up to 122 degrees Fahrenheit. I think that the important thing to think about in this that I understand for the patient is looking at for them, some type of an option that is going to save their life or medication like Neffy. It's definitely a pathway that we have to have available for our patients, and also those patients that may have anxiety from needles or phobia from using them. And I actually have an Neffy. This is the actual plume.
Your time is up now.
And oh, okay, perfect. That's it.
Thank you. Any questions from the committee? All right, thank you. Next up, we have Dr. Rendell for Valtoco.
Hi, my name is Amanda Rendell, and I'm a senior medical science liaison with Neurelis. We would like to thank you for your recommendation to maintain Valtoco in a preferred position. With that, I'd like to give my time back to the committee, but will remain on the line to answer any questions you may have. Thank you.
Any questions for the committee today? All right, thank you very much. Next up, I have Dr. Hampshire for Sublocade.
It's okay. We can come back.
We'll come back. Next up, and Joe, I butcher your last name every time, so I'm just gonna call you Joe because I just can't seem to get it, but
That's all
Opzelura.
right. We'll go with that. As you said, my name is Joe Scrincione, pharmacist and health outcomes liaison with Insight. I just had two brief updates on Opzelura. Starting off with an update on the indication. So September 18th, the FDA approved Opzelura for the treatment of children aged 2 to 11 with mild to moderate atopic dermatitis. This is the same strength and dosing of Opzelura as used in adult patients. And I just want to thank you for the age limit expansion and your recommendations. Of note, Opzelura is still indicated for patients 12 and older for non-segmental vitiligo. And then lastly, we have new real-world evidence. Previously, I presented 12-month real-world evidence. Here's an update to that using 18-month claims data. So a retrospective observational cohort study. The study showed that after starting Opzelura, patients used an average of 2.4 tubes of Opzelura in 18 months. 91% of biologic naive patients at baseline remained biologic free during the 18-month period after starting Opzelura. And close to 36% of biologic experienced patients at baseline did not continue their biologic therapy in months 13 through 18 after starting Opzelura. As for safety, the prescribing information for Opzelura includes box warnings for the risk of serious infections, mortality, malignancy, major adverse cardiovascular events, and thrombosis. Please refer to the prescribing information for the full indication statement and safety information. We want to thank the committee for the continued preferred recommendation for Opzelura, and Insight respectfully asks the clinical criteria be updated to a trial of a topical corticosteroid or a topical calcineurin inhibitor to match the other preferred agents. Thank you for your time. I'll answer any questions you may have.
Any questions from the committee? Are you formulating a question, Dr. Shaw? Are you good? Okay. You looked like the wheels were turning, so I was just trying to decide. Did Dr. Hampshire step back in for Sublocade?
Given time back. Right here.
You are perfect.
Great. Hi, everybody. Good morning, and thank you for the opportunity to speak with you today. My name is Cambridge, and I'm a pharmacist on Indivior's medical team, the manufacturer of Sublocade. And we appreciate the committee's continued support for Sublocade on the preferred drug list. At the same time, clinicians share that one of the remaining challenges to treatment continuity is the manual prior authorization process. Even short delays can interrupt care for patients, especially in today's fentanyl-driven environment where the treatment window is often very short. In a large Medicaid analysis presented at AMCP, patients with higher proportion of days covered on Sublocade experienced significant reductions in healthcare utilization, including fewer inpatient admissions, fewer ED visits, fewer detox admissions. And each increase in PDC was linked to fewer costly events, showing that when patients stay on therapy, outcomes improve and healthcare costs decline. The FDA's recent label updates support this same principle of continuity. Patients can now receive Sublocade after a single test dose of transmucosal buprenorphine, even having never been on a buprenorphine product before. And so that was approved using our rapid initiation study, which showed that this new rapid initiation induction is non-inferior to the 7-day induction. And then patients also had better treatment retention, early treatment retention, and sustained treatment retention off rapid initiation dosing. And so taken together, the data shows that streamlined access helps patients stay engaged, lowers healthcare utilization, and supports recovery. And so we respectfully ask that Indiana Medicaid transition from a manual PA to an electronic PA for Sublocade to reduce administration delays and help clinicians maintain treatment continuity. And I appreciate your time and open to any questions you might have. Right at 2 minutes.
Any questions from the committee?
Amanda, just a clarification.
Yes,
So,
Brian.
Cambridge, this is Brian Musial. My question is related to your question, concern, however you want to address it, relative to a manual PA versus an electronic PA. I just want to reiterate that all the MCOs and fee-for-service all have a 24-hour turnaround time on a prior authorization, whether that is done manually or done electronically, it doesn't matter. So that turnaround time is pretty good in terms of the world of treatment. So I'm curious how you anticipate a change in that 24-hour turnaround time by migrating from a manual to an electronic PA.
Yeah.
I
and so-
suspect that most MCOs and fee-for-service are probably turning around these PAs within, I'll say 2 to 4 hours.
Yep.
And so I'm not convinced that that full transition. And trust me, the MCOs and I'm sure fee-for-service are moving that direction, but I don't know that it's going to change an outcome for a particular patient based on that 24-hour turnaround time. Just kind of clarifying that.
And that's helpful context. It was my understanding that when you have a manual PA and a patient comes in having already tried and failed a buprenorphine product, it is on label to start Sublocade right away when the patient is there in the facility. So an electronic, almost instantaneous look back would be helpful, but it sounds like you would still have that 4 to 5 hour delay even with an electronic PA, correct? Because we just don't want patients coming in, trying to get treatment, and then they can't get it, and even 4 to 5 hour delays or 24-hour delays. Oftentimes this patient population, fentanyl users, may leave and relapse in that time period.
Understand. Appreciate it.
Yep. Thank you. Any other questions?
Thank you. Apologies all if you're like, where did the screen go? Apparently all of us Optum folks, I don't know if anybody else, just had the state's Wi-Fi kick us all off. So we're frantically trying to get on our hotspots at the moment, but in order to continue, we do have another page of speakers. So next up I have Dr. Berner with LYBALVI and Aristada.
I would like to thank the committee for placing Aristada and LYBALVI as preferred agents, and I will respectfully give back my time and happy to answer any questions pertaining either to LYBALVI or Aristada.
Any questions from the committee?
Thank you.
Thank you. All right. I'm just almost there. Hopefully there we go. All right, next up I have Dr. Riato for Caplyta and Invega.
Hello, thank you. My name is Tamara Rito, and I'm a pharmacist and a principal scientific account lead with Johnson & Johnson. Thank you for your time today. Excuse me. For Caplyta, I would just like to do a brief update. I would like to thank the committee for your clinical consideration in selecting Caplyta for preferred status on the Uniform Preferred Drug List. Just brief update. Yesterday, we received approval for treatment of major depressive disorder in adults, and we would just like to give a brief update. So now it actually has three indications: adjunctive therapy with antidepressants for the treatment of major depressive disorder in adults, schizophrenia in adults, and depressive episodes associated with bipolar 1 and bipolar 2 disorder or bipolar depression in adults as monotherapy and as adjunctive therapy with lithium or valproate. It's a once daily dosing regimen with no titration required. It does have a boxed warning for increased mortality in elderly patients with dementia-related psychosis and suicidal thoughts and behaviors. Please see the full prescribing information for complete information. In 2 multi-center phase 3 studies of adults with major depressive disorder, Caplyta, as with adjunctive therapy with antidepressants, showed a statistically significant improvement in MADRS total scores compared to placebo adjunctive to ADT from baseline at 6 weeks. And in long-term 26 weeks open label study, changes were minimal in measures such as body weight, metabolic lab values, and prolactin levels. And the extrapyramidal symptoms and weight gain were comparable between the Caplyta treatment and placebo groups. And the most common adverse effects included somnolence and sedation. So once again, we thank you for your clinical consideration today, and I'm available for any questions. And then our second topic, which was Invega Halfiera, we will respectfully yield our time back to the committee. And again, we thank you for consideration for placement of Invega Halfiera, Invega Sustenna, and Invega Trenza on the unified preferred drug list, and available for any questions as well. Thank you.
Any questions from the committee? All right, thank you very much. Next up, we have Dr. No for Zoryve.
Thank you. My name is Crystal Ngo, and I'm the Director of Medical Values and Outcomes at Arcutis Biotherapeutics, speaking to Zoryve foam and cream. I wanted to provide a few updates regarding Zoryve. In May 2025, Zoryve 0.3% foam was recently approved for scalp and body plaque psoriasis in patients 12 years and up. Last month, Zoryve 0.05% cream was approved for the treatment of mild to moderate atopic dermatitis in patients 2 to 5 years of age. For Zoryve 0.3% cream, the pivotal Erector study demonstrated a statistically significant percentage of patients achieving scalp and body IGA success at week 8 when comparing Zoryve 0.3% foam to vehicle. Thank you for updating this as part of your PA criteria. For Zoryve 0.3% foam, it was well tolerated with low incidences of adverse events. For Zoryve 0.3% foam, it's uniquely formulated to make application to the scalp and other hair-bearing areas easier. Patients with psoriasis affecting both body and scalp may require several topical products to address different application considerations. And Zoryve 0.3% foam is a single topical option for patients that is efficacious and well tolerated for the treatment of scalp and body psoriasis. For Zoryve 0.05% cream, this was studied in the pivotal trial INTEGUMENT-PED in patients 2 to 5 years of age. In a statistically significant greater portions of patients achieved the primary endpoint of IGA success at week 4. Zoryve 0.05% cream was well tolerated, and the safety profile observed in the open label extension was generally consistent with the safety profile observed at week 4. Durable effectiveness was also observed in the 56 weeks of treatment, where the patients achieved IGA of 0. 30.2% was switched to twice weekly application with the median duration of those maintaining disease control was about 238 weeks, or about 8 months. Zoryve foam and cream is a once daily steroid-free option with no label restrictions on duration of use. So with that, we respectfully request Indiana Medicaid to have Zoryve 0.3% foam and 0.05% cream to be added to formulary as preferred with a single step through topical corticosteroids. Thank you so much for the committee for your time and consideration, and I will open it up for any questions the committee may have.
Any questions? Thank you. I am running my timer, even though it doesn't look like I'm running my timer. I don't know. It's probably likely because I'm using my phone to hotspot in. So, oh, wait, it's back up. Okay. So bear with us. If you can't see the timer, I'll let you know as we go through. Next up, I have Dr. Hamoud for Feburain.
Yeah, can you hear me okay?
Yes, we can.
Good. Well, thank you. My name is Jalanat Hamoud. I'm pharmacist by training and MSL here at MedUnique. Thank you for the preferred status for Feburain. I would just to give a brief and quick summary for the drug. Sodium phenylbutyrate is a nitrogen scavenger drug established decades ago as the gold standard adjunctive therapy to the standard of care for urea cycle disorder, has changed the prognosis of this condition by saving patients' lives and improving drastically their outcomes. Sodium phenylbutyrate non-coated formulation was approved for marketing as Bufenil in the United States in 1996. However, bad taste or taste aversion are amongst the most frequent adverse events reported with this non-coated formulation. And since the commercial non-coated formulation have an offensive taste and improved tasteless pellet formulation of sodium phenylbutyrate, Feburain was developed, whereby coating of individual pellets results in a formulation which has no immediate taste. And in French compassionate program cohort, In comparison with the non-coated formulation, Fiburain showed high acceptability, no vomiting, and ease of administration without any reconstitution, and an improved control of ammonia plasma levels with no hyperammonemia crisis up to 30 months. Therefore, we thank you for the continuous preferred status, and we will answer any question you might have. Thank you.
Any questions for Dr. Hammoud? All right, thank you. Next up, we have Dr. Eaton for Vitama.
Hi, good morning, everyone. Thank you so much for the time and for having us. My name is Rachel Eaton. I am a pharmacist by training. I'm now a medical director here at Organon. Before I begin my testimony, I just wanted to confirm whether Vitama is being moved to the immunomodulator class for atopic dermatitis in the preferred position.
It's moving.
Yes, that's one of the indications covered in that class, but yes.
Perfect. Okay, for atopic dermatitis for the preferred position. Well, great. Well, thank you very much. In that time, I will yield my time back to the committee. I'm happy to take any questions.
Any questions for Dr. Eaton? All right, thank you very much.
Thank you so much.
Next up, we have Pam Eads for Fintepla.
Thank you, and good morning. I apologize for my voice. I'm a little bit under the weather today. Not great timing. My name is Pam Eads, and I'm a medical outcomes liaison for UCB, and I'm here to discuss two rare forms of epilepsy and UCB's product Fintepla. Dravet syndrome and Lennox-Gastaut syndrome, known as LGS, are severe treatment-resistant rare epilepsy syndromes. In the United States, the estimated Dravet syndrome incidence rate is about 1 in 15,000, and LGS affects 1 to 2 patients with epilepsy. Both syndromes are characterized by seizures, developmental delay, and intellectual disability. Uncontrolled seizures can lead to serious and life-threatening complications, such as status epilepticus and sudden unexpected death in epilepsy, known as SUDEP. The 2022 International Dravet Syndrome Consensus Statement recommends the use of Onfi, Diacomet, or Fintepla as first or second line therapy. There are no consensus guidelines for LGS. Currently, Indiana Medicaid requires trial and failure of Epidiolex and Diacomet before approving Fintepla for Dravet syndrome, and a trial and failure of Epidiolex before approving Fintepla in LGS. Considering the seriousness of these uncommon epilepsy syndromes, the consensus statement, and the information in your DUR packet, we ask you to consider providing Fintepla with the same access as other medications indicated for Dravet syndrome and LGS. Fintepla is approved for the treatment of seizures associated with both Dravet syndrome and LGS in patients 2 years of age and older. Fintepla's efficacy and safety in Dravet syndrome were established in 2 randomized controlled trials that both met the primary endpoint of reduction in convulsive seizures per 28 days, which was significantly greater for all included doses of Fintepla compared to placebo. Fintepla's efficacy and safety in LGS were established in a randomized controlled trial, which met its primary endpoint of reduction from baseline and monthly drop-related seizures in the Fintepla higher dose arm compared to placebo. The seizure type with the greatest median percentage change was generalized tonic-clonic seizures. Fintepla has a well-established safety profile. Fintepla has
Pam?
a black box warning.
Yes. That's your 2 minutes.
Okay, thank you. I'm here to take any questions if needed.
Any questions from the committee? Thank you. Next up, we have Kenneth Mendez for Neffy. All right, I am not seeing them. Then we have Elizabeth Johnson for Zurzuvae.
Yeah, hi. Ms. Johnson had to drop off the call, but she texted me letting me know she'd like to yield her time back to the committee. So thank you and have a great weekend.
Perfect, thank you. Next up, I have Dr. McFadden with Abilify, Asimtufii, and Rexulti.
Good morning. Can you hear me okay?
We can.
All right, and thank you for the opportunity to provide public comment this morning. Based on the recommendations, Otsuka Pharmaceutical would like to thank the committee for maintaining Abilify Asimtufii and Abilify Maintaina, as well as Rexulti at preferred status. And I'd like to respectfully yield my time back to the committee this morning, but I'm happy to answer any questions.
Thank you. Any questions for Dr. McFadden? All right, thank you very much. Next up, we have Gretchen Johnson for LAI buprenorphine.
Good morning. Can you hear me?
Yes, we can.
Thank you. I'd like to thank the committee for all you've done to make LAIs more accessible for patients. Two quick asks. Well, my large ask is always a respectful request to remove the prior authorizations from both Sublocade and Brixadi, but I think two smaller, perhaps more palatable asks are, one, to allow providers for Medicaid patients to choose which specialty pharmacy through which to prescribe the LAIs. For example, it appears that CareSource HIP requests that we prescribe through Accredo instead of in my facility, Community Health Network Specialty Pharmacy, or something more local like Genoa, and the turnaround times are vastly different depending on which pharmacy you use. And then the second ask is, lately, it started with Anthem HIP, but appears to be other plans as well. We've had to submit specific documentation from the provider explaining why sublingual buprenorphine is not preferred. And that's causing some significant delays between the inpatient providers putting in the script and the prior authorizations being approved, because there's been some denials with the logistics of the prior authorizations being submitted by the pharmacist without the appropriate documentation, because due to 42 CFR regulations, they don't have access to the appropriate notes sometimes. So it's been a bit of a back and forth and causing some significant delays, and I'm not sure what changed on that. That's now making that a requirement. I only have a few seconds left, so I'll just say thanks again for all you've done, and I'm here for any questions regarding those two requests.
I just want to point out, per state law or per our regs or the policy, I guess, rather, for Indiana Medicaid, pharmacists are not permitted to submit PA unless they're part of a doctor's office or working on behalf of a doctor's office. So truly the PA needs to come from the prescriber's office or somebody working within that office to provide, so that they can provide the documentation. Only the prescriber should have the access to the documentation that's needed. And that is the current PA criteria across the board about rationale as far as why the oral is unsuitable for use, which is vastly related to the exponential cost difference between the two. And so if people can be treated with the oral, that's why they're looking at that. And I know Dr. Kuhn was looking at me from OMPP, so she might have comments to add. But as far as the managed care groups, they are able to choose their own specialty pharmacies. So do you have anything you wanted to add to that, Dr. Kuhn, or?
Yeah, we did reach out to our managed care partners, and we have asked them to look into their pharmacy networks for some additional options other than, I know historically, some of the specialty pharmacies, we've had some concerns with access there. So I don't know if any of the pharmacy directors want to provide any further information on that, but we have asked them to look into expanding their networks for these particular products.
Thank you.
I know
Hey,
there
Amanda,
are some things. Yeah.
It's Jen Chapin at CareSource. Am I able to speak on this?
Yes. Yes,
Okay,
Dr. Kuhn
great.
opened the world to you, so you may.
Wonderful. Thank you so much. Yes, absolutely. So I wanted to follow up in response to the CareSource comment and let you know that we did subsequently add Genoa to our network. So you should be able to fill Brixadi there. And if you're having any issues or have any additional questions, you can feel free to reach out to me as well. I can pass along my contact information.
Okay, thank you so much.
Thanks, Jen. Any other comments from any of the other managed cares? I didn't want to not give anybody else a chance to speak, should you so desire to.
This is just Amy with Anthem, and I just wanted to kind of reiterate, I think, what was said, that based on the concern shared with Anthem's criteria, I do believe we're following the SUPDL criteria. So if there are concerns, by all means, please don't hesitate to reach out.
Thanks, Amy. Anyone else or any other questions from the committee? All right. Thank you, Dr. Johnson.
Thank you.
Next up, we have Heather Metzger, also for LAI buprenorphine. Oh, there she is.
Oh, can you hear me?
We can.
All right. So I just wanted to hop on here and just like many others have, thank the committee for your continued work to help us make LAIs an option for our precious patients and this population that we serve. But I also wanted to kind of piggyback on Dr. Johnson's comments about the cumbersome prior authorization process. And I actually just within the last 2 weeks had a patient come to my clinic. He had tried multiple times oral buprenorphine, had continued use. There were issues with him managing, with him taking it, all the things. Someone from his sober living facility or facility he was staying at told him that he was diving on Brixadi, and that he could, change the dose or have a say, all the stuff. So he came in rip-roaring, ready to do the injection. But the process and the time that it was going to take to get the PA completed was a turnoff, or he was upset or fussy or whatever. And unfortunately, that individual did not return for follow-up. And so I know that story is one of many, and if we could somehow find a way to remove prior authorizations or how cumbersome they are, that would be wonderful.
So I want to echo one of Brian's Musial's comments he made earlier around the 24-hour turnaround time. So there is a 24-hour turnaround time for those PAs. And I do believe, Heather, both you and Dr. Johnson have my emails in case you are having any struggles with PAs. I'm yet to receive, I think I received 1 or 2 from you that I forwarded on, but otherwise haven't received any. So please do continue to escalate and forward any issues that you encounter if you encounter delays, because while I recognize you have to complete the PA and send it in, it should be a 24-hour turnaround time within that time frame, if not quicker from their submission.
Yeah, sure, I understand. Sorry, did I interrupt someone? I was just gonna say, so yeah, the PA process in itself is 24 hours, and oftentimes, but then if it's denied for some reason, like for example, this gentleman took well, he had been taking around 4 milligrams of oral buprenorphine, so that made him a candidate or not a candidate for Sublocade, I guess I'm trying to say. So I presumed right away that I would have less of a time frame, but with the patient having CareSource as his insurance, sometimes it takes longer with certain, or no, maybe he didn't have, I don't remember honestly what kind of Medicaid he had, but the time frame that it was going to take after the prior authorization and then to get it through the pharmacy and then get it shipped, would be 5 to 7 days or whatever. I don't know, but just that it took a significant amount of time, I guess, in his eyes. So I guess my point is to that's just one example of how having a requirement of a PA is difficult in this population. Maybe that is a better way to state it.
Understood. And again, would continue to please any things that you're encountering around delay escalate, but anybody from the committee?
We're working on that. It's just, this is all that was not the top of the list for this 24 hours.
Sure. Any other comments or questions from the committee? All right, thank you very much. Next up, we have John Eckerd, Dr. Eckerd for Cobenfy.
Yeah, thank you. I'm a psychiatrist. I, have been in practice, I guess, for 30 years, and I work with, in part, I work with some group home patients who've been, like some of whom have come from the state hospital and, treatment resistant situations. And I've just found that, Cobenfy, it's the first new product we've had for schizophrenia in a long time. It offers a lot of unique advantages with, in terms of, it doesn't have the metabolic side effects and motor side effects, and it seems to do better with negative symptoms for schizophrenia. I guess what I'm kind of asking for is, I'd like to see some improved access for patients. There's an attestation that's required with Cobenfy, and it's required to be a single agent. That's not really required with other types of, with the atypical antipsychotics. So, we can, in these kind of treatment resistant situations, use two antipsychotics if somebody's like been on clozapine or what have you. So, having that availability or that flexibility would be useful. I thank you all for your time.
So, Dr. Eckerd, you are a psychiatrist?
Yes, I am.
So your request is to be able to access Cobenfy in terms of using it as a duplicate antipsychotic with less restrictions or oversight.
Yeah, and there's I guess there's an attestation that's required, where you have to sign off that in terms of that it's not being used as a single agent, that it's not used, the patient doesn't have urinary retention and gastroparesis and so on. In treatment resistant situations, it does happen where we'll have people, who've been through clozapine, who've been through, multiple antipsychotics. Sometimes they're on two antipsychotics. And Cobenfy doesn't have that flexibility to add it in if we, have somebody who's in a treatment resistant situation.
Because this is like a class that's sort of new to T committee. But so we have like a gold card program for neurologists. Do we have like a gold card program for psychiatrists? No.
We do not.
Okay. Would that make life easier or more expensive?
A gold card program?
So this is Carol. That has been in the 20 years of the Mental Health Quality Advisory Committee, the concept of a gold card for psychiatry for various types of medications has been tried before. And it was cumbersome to administer. And then there were challenges because there are various other providers who are also writing for this, and how you incorporate the psychiatry gold card into when a patient's transferred to another provider became very difficult. So it wasn't something that was useful at the time. And I don't know, Amanda and Courtney, if you have any thoughts about that, but that has been tried before in the Mental Health Quality Advisory Committee.
Okay.
It has, and it's it is a hugely cumbersome thing to do, like just systematically and then following up and back checking individuals. And unfortunately, I think one of the things that we encountered, and Dr. Rock, correct me if I'm wrong, but even with psychiatry, we had a lot of inappropriate prescribing in children when psychiatry was
Yes.
allowed to do some things that wasn't supposed to be there. So I'm not saying every psychiatrist is like that, of course. I'm not trying to like globally say all psychiatrists are, but we've just had some historical problems.
Okay. Yeah, so I might ask you, Dr. Eckert, I mean, if you want to look at the criteria to see how it may be somewhat pared back, I think you've heard we've tried more direct access for psychiatrists, and it's not worked out terribly well or very efficiently. But I mean, we've always been very willing to try to pare back the amount of complexity with.
I think one of
step
his
methods.
comments around the dual use, the reason that it's not allowed for dual use right now is there's no data to support dual use. And so as soon as there's manufacturer data supporting that use, they're doing the trials right now. Like as soon as we have that there's data to support its use that way, then we would update the PA criteria to be consistent with the other agents.
Yeah, I guess, I mean, my comment about that would be that, you know, we are currently allowed to use two atypicals together, and there are situations where that's, you know, considered appropriate. And again, what I'm talking about is, in this case specifically is, you know, patients that are pretty much by definition treatment resistant, you know, they come out of the state hospital and or they're preparing potentially to go into the state hospital.
Yeah, we understand that. I think it's that there's evidence base to support those agents in duplication in certain individuals. Like I don't know if you were on earlier when we were talking about like if somebody's schizophrenic and they've used a singular agent, then they need to use clozapine first if they can before going to duplicate therapy. So there are agents that have the evidence base to support it. There just hasn't been evidence-based yet for Cobenfy. And I know, Dr. Ott, we talked about this at the Mental Health Committee meeting at one point around that. I don't know if you have anything additional you want to add to that as well.
Yeah, I think it's not the specifically the dual use. This is a very different drug than the atypical antipsychotics. I mean, the way its mechanism of action is not D2,5-HT2A antagonism. And so the issue is really more around safety data in combination with other antipsychotics. And that's just what we don't have yet, because those anticholinergic effects can be really problematic. And as we add them to other antipsychotics, we just want to make sure there's safety data out there. That's what we don't have. I mean, you know, you can get an evidence base around use, even case reports of combination use. And that's what we had for a very long time for effectiveness, but we didn't have a lot of safety data. And so I think because the other atypicals have been used in combination for a while, there is some comfort level with safety data, and that's just what we don't have yet for Cobenfy. And as soon as that is available, that is something that Medicaid will definitely take a look at. Amanda, does that help?
That is 100% accurate as I remember it.
Okay, thank you.
So Dr. Ott, I mean, so looking at the criteria for Cobenfy, I can understand that maybe if it's a non-psychiatrist prescriber, that having the attestation may be helpful. Do you think it's helpful to have it for psychiatrists?
Right now, given the history of what we have worked on within the Mental Health Quality Advisory Committee, it's until we have more safety data, I think it's appropriate.
Okay. Okay, so it's essentially we need more experience and more data.
Right. I mean, the reason why the urinary retention, I mean, I totally understand. I practiced in psychiatry for over 30 years, and I very much understand when we get to treatment resistance, And being able to add another medication with a complementary mechanism of action that isn't duplicative is appealing. But the issue of the urinary retention is in the clinical trials was pretty concerning to be able to monitor for that. And so I think that's where we are with Cobenfy. I absolutely agree that it, from a metabolic perspective and a movement disorder side effect perspective, it's an absolute step forward. I also think it's more of a first line drug than a treatment resistant drug, if I'm honest, because I think we wait too long to use these really effective drugs sometimes. But as a pharmacist, my concern is adding in additive side effects that put people at risk for things like bowel obstruction and, other urinary tract issues because of those anticholinergic effects. And I think we just need a little more time, a little more post-marketing time.
Thank you.
Any other questions or comments from the committee? All right. Thank you very much, Dr. Eckerd. Next up, we have Brooke Kemp, also for Cobenfy.
Good morning. My name is Brooke Kemp. I'm a psychiatric mental health nurse practitioner. My background is community mental health. I worked in our local community mental health center for 29 years. I don't want to waste committee's time. I want to try and just add a couple things to everything that was just discussed. Primarily looking at what we were just discussing, I think the key comes to, as a prescriber, I am so excited that we have this new mechanism of action. As Dr. Ott mentioned, I agree this needs to be used earlier in treatment. Because of my history working in community mental health, I've seen the decades, the damage that this illness can do to patient over time. You see loss of functioning. So many different aspects of patients' lives are affected by this illness. Here we have this new mechanism of action that can target different symptoms than we ever have before. And yes, it has a different safety profile that we as clinicians need to learn how to address. But I have worked really hard at decreasing stigma when it comes to mental health, and I admire this committee's work in allowing mental health medications to get to our patients. But one barrier is always those prior authorizations, and I really just want to emphasize this medicine is different. That list of antipsychotics that we saw, this is the only one with this unique mechanism of action. Therefore, I feel it needs to be preferred. When we're combining this with other medications as clinicians, we need to understand those anticholinergic burdens, but we've been allowed to combine other medications with anticholinergic properties before. Here, the data shows us that we need to be able to use this earlier so that we can address all the symptoms. When it comes to the combining of medicines, it's the titration time. We can't have restrictions on how long it's going to take us to titrate because schizophrenia is too complex. I wanted to end that right at that 2-minute mark. Anything else that you have questions of me or anything else I can elaborate on?
Any questions for Brooke? Thank you very much.
Thank you.
Last on the list, we've got Dr. Chotsky for Veozah.
Hi, good morning. Thank you for the opportunity to speak today regarding Veozah. My name is Jeanal. I'm a pharmacist on the Medical Value and Access team at Astellas. Before I proceed, can I please have clarification on the status of the PDL and category?
Yeah, I think it's non-preferred in the estrogen and related agents. I don't believe we made any changes.
Okay. I submitted a publication for your review via email. It was a systematic review and network meta-analysis comparing the efficacy of Veozah with non-hormone therapies. And this analysis provided comparative data on fezolinetan's efficacy relative to other available treatment options. And the analysis showed that fezolinetan reduced the daily frequency of hot flashes significantly more than all non-hormonal treatment options evaluated. So with that in mind, we respectfully request the committee members to consider dropping non-hormonal step therapy requirements. I'm happy to take any questions from the committee regarding the publication I submitted.
Any questions from the committee? $11. Sirens going off here. All right, thank you very much. I believe that ends our public comment and then leaves us with other business. Any other business from the committee? All right, so folks, it's 11. Normally we start our third session at 11. Clearly, we will not be doing that today. So we do need to go as rapidly as possible into our second closed session. For those of you on the committee, you should have that invite. Please join us over there. I know it's been 2 hours already, so if you need a bio break, we'll allow it. Just this once though. And then we will start the third session whenever we get done with the second session. So I wish I could give you a time. I really don't. Do we want to just say no earlier than noon so we know that, like, so people know when they have to join back in? I think it'll take us at least an hour anyway. So we will start the third session no earlier than noon, but if we are not there at noon, we are still going in the second session. Okay?
So start second session, maybe 11:15, give people a little bit of a break.
Yeah, so those on the committee will start at 11:15 for the closed session. Give you a chance to take a break. All right, thanks, everybody.